Good afternoon, ladies and gentlemen, colleagues. It's a great pleasure to have you this afternoon for this symposium entitled Thinking Dengue Again, Chronicity, Antibiotics and Vaccination. So in this hour-long symposium, we have three excellent speakers to take us through various aspects regarding dengue. And it's my privilege to be able to chair this session for you. My name is Dr. Asok Kurup, and I'm an infectious diseases physician. So without further ado, I would like to invite Dr. Theodore Tsai. Dr. Tsai is a vice president and head of immunization science and policy within the Global Medical Office of TAKEDA Vaccines. He's an alumni of Johns Hopkins, and he had also served as an Epidemic Intelligence Service officer at the US CDC. He was also a commissioned US Public Health Service officer and also at the Viral Special Pathogens branch in Atlanta, where he was responsible for several activities, including surveillance, lab diagnosis, and field and lab studies of viral hemorrhagic fevers and arboviruses. He subsequently joined industry, where he has worked on the development and implementation of vaccines for not just flu, but other respiratory viruses, as well as Japanese encephalitis, dengue, and so on. So it's my great privilege this afternoon to invite Dr. Tsai to discuss, and the title of his talk is Chronic Diseases Are a Risk Factor for Dengue Severity, Observations and Implications. Dr. Tsai, please.
Thank you very much for that kind introduction. I'm speaking to you from Boston, but good afternoon, everyone. Today, I'll briefly review the impact of chronic comorbidities on the clinical course of dengue and their broader implications. Next slide, please. Next slide again, please. I'll describe first the rationale for and results of a recently completed study in Taiwan that was co-led by our next symposium speaker, Professor Huang, and a graduate student at the Harvard School of Public Health, Alan Lien. Next slide, please. Next slide, please. Thank you. I'll start with this table that will look somewhat familiar to all of you because it displays a list of conditions of groups of people who are at high risk for COVID that were prioritized for immunization. This particular list comes from the UK, but the conditions identified as posing a high risk include chronic cardiorespiratory, kidney, liver, neurological, metabolic, immunocompromising, and other conditions. And these are agreed generally. Next slide, please. A virtually identical list is shown here of conditions posing a risk for seasonal influenza. And this forms the basis for seasonal vaccine recommendations in most countries. Next slide, please. So it's really no surprise that for dengue, another acute viral infection, that chronic comorbidities might also pose a risk for more severe disease. This 2016 meta-analysis from Public Health Agency of Canada showed that underlying diabetes, hypertension, heart disease, and increased body mass index conferred a 1.6 to 3.4-fold higher risk to develop severe dengue. Next slide, please. A more recent and larger meta-analysis from Imperial College focused on conditions during the acute phase of illness that were associated with progression to severe disease. Now, the sub-analysis in children showed what all of you know, that secondary infections confer a very strong 2.8-fold higher risk for developing severe disease. In adults, however, looking at the bottom, that odds ratio is lower, 1.5, and is overshadowed by higher risks associated with underlying diabetes, kidney, and heart disease. So this suggests that underlying comorbidities in adults contribute significantly to risk for developing dengue in contrast to children, where severe disease is driven by an ADE-mediated pathogenesis. Next slide, please. So these observations provide context for our study. Next, please. In Taiwan. But first, it's important to understand that in Taiwan, dengue is not endemic. The virus is introduced frequently, however, resulting in focal outbreaks, and so the seroprevalence in the general population is low. In 2014 and 15, however, there was a very large outbreak resulting in more than 51,000 cases, more than 11,000 of whom were hospitalized. And adults in these two outbreaks formed the basis for our study. Next slide, please. We exploited the various linked databases available in Taiwan, including the National Health Insurance Research Database that covers 99.9% of the island's population. Medical claims made to this database were linked to the CDC list of confirmed dengue cases and then to vital statistics of certified deaths. So for each case from the confirmed date of onset of illness, we looked back 1 year to ascertain specific chronic conditions, and then forward 30 days to identify hospitalizations, ICU admission, length of hospital stay, medical expenditures, and deaths within that 30-day period. We did not review medical records of individual patients and relied on hospitalizations and ICU admissions as proxies for severe disease. Next slide, please. So at the upper left, so the primary objective was to assess the impact of multiple pre-existing chronic conditions that will be shown on the next slide, and on clinical outcomes of dengue and healthcare utilization. Next, please. So at the upper left, you see that compared to individuals without chronic comorbidities, hospitalizations in people with comorbidities was elevated for most of the conditions. In the middle, ICU admission was seen more frequently in patients with underlying diabetes, coagulation disorders, hypertension, CHF, COPD, rheumatoid arthritis, and chronic kidney disease. And deaths at the far right occurred more frequently in patients with underlying malignancy, diabetes, CHF, COPD, rheumatoid arthritis, chronic kidney disease, and cirrhosis. Unsurprisingly, you see below that many of these conditions led to longer hospitalizations and greater inpatient and total medical expenditure. Next, please. In addition, there was a clear trend for greater morbidity, mortality, and healthcare utilization with each additional comorbid condition. So the cumulative burden of multiple comorbidities is associated with, is consistent with the association with frailty, which we know in other acute viral infections can lead to more severe outcomes. Next, please. In addition, acute infection can result in frailty or can exacerbate existing frailty. So this study of older adults hospitalized with acute viral respiratory infection showed that in 18% of the survivors, there was a functional decline, 8% experienced a moderate decline, and 10% a catastrophic decline. So the important message here is that after an acute setback, such as a hospitalization, a significant fraction of older adults will suffer a functional decline from which they never will recover. Their functional status has been ratcheted back. Similarly for dengue, that acute insult in a vulnerable individual can lead to a more complicated clinical course and a more difficult recovery. Next slide, please. So our study confirmed that a specific underlying chronic diseases exacerbated the course of acute dengue, resulting in a higher frequency of and prolonged duration of hospitalization, a greater need for ICU care, and a higher risk for fatal outcome. The dose-response relationship between the number of comorbidities and adverse dengue outcomes suggests that frailty may be a determinant of these consequences. As dengue is not endemic in Taiwan, most cases were primary infection. Therefore, as was suggested in the meta-analysis that I described earlier, dengue severity in adults may be directed more by underlying health status than ADE-mediated pathogenesis. Next slide, please. So our conclusions are limited by reliance on administrative data only, and individual medical records were not reviewed. So we were unable to confirm primary from secondary dengue infection. We could not exclude confounding from factors such as elevated BMI because those data were not available in the database. Out-of-pocket expenditures were not quantified, and we could not rule out underreporting of mild cases. But importantly, generalizability to other countries may be limited. For one, we were unable to assess the effect of sickle cell disease because of the geographic distribution of that disease. So I'll amplify on that point later. This study measured the impact of chronic diseases on the clinical course of dengue. The converse, the impact of dengue on the trajectory of those chronic diseases, was not studied. Next, please. So the broader implications of these observations, next please, stem from the impact of development on both demographic trends and dengue epidemiology. Development is accompanied by lower birth rates and longer life expectancy. Lower birth rates decreases the flow of susceptible individuals into the population, and longer life expectancy leads to a greater proportion of the population that is immune. So this leads to a lower force of dengue infection so that the infection is acquired later in life. You see at the upper right that with increasing GNI per capita, gross national income, that the force of dengue infection declines. And at the bottom, with increasing GDP per capita, that the proportion of dengue deaths in adults increases. Next slide, please. Now, the converging consequences of development on dengue and on non-communicable disease epidemiology, NCDs, are depicted in this figure. So development is associated with increasing prevalence of non-communicable diseases and also a lower force of dengue infection. And the latter leads to dengue being acquired in later stages of life. So this means inescapably that a greater proportion of dengue cases will have underlying NCDs. And as you've heard, specific NCDs can lead to a more severe course of dengue. So the global burden of dengue increasingly will represent the prevalence of and complications from these underlying conditions. Next slide. So before concluding, I have to take a detour because I'd be remiss not to mention the significant risks for severe dengue in patients with sickle cell disease. Many studies, pardon me, in the Caribbean and South America have shown that patients with SS disease and in particular SC disease have significantly higher risks for severe complications from dengue, including severe dengue in 1/3 to 1/2 of patients, and fatal disease in 4.5% to 22% of SS and SC patients, respectively. These are massively elevated case fatality rates, which you know typically are in the range of 0.1% to 1%. So vaccine recommendations need to recognize these higher risks in sickle cell disease. In Asia, patients with alpha and beta thalassemia may present with anemia instead of hemoconcentration, and they may have a more complicated but usually not fatal course. Next slide, please. So to summarize, specific chronic diseases are associated with increased risks for severe dengue, longer hospitalizations, ICU admission, and higher mortality and healthcare costs. Clinicians should be cognizant of these risks to anticipate the potential for a severe clinical course in patients with underlying diseases. And risk conditions should be identified in national immunization and routine immunization and catch-up programs and recommendations for travelers. Next slide, please. Thank you.
Thank you very much, Dr. Sai, for that illuminating talk. I would like to invite the audience to participate in the question and answer session, which will follow after our two subsequent speakers. But next up is Professor Nicole Huang, who is the Director of the International Health Program at the National Yang Min Chiao Tung University in Taiwan, where she holds several important portfolios, including the Vice Dean of College of Medicine and the Director of the International Health Program, Professor at the Institute of the Hospital and Healthcare Administration, and an adjunct professor at the Institute of Public Health. She did her MPH at Boston and also had the PhD of Health Policy and Management from the Johns Hopkins. So she's going to talk to us today about dengue and its effects on antimicrobial resistance. Professor Huang, please.
Thank you very much for your kind introduction. And good afternoon, everyone. And I'm really glad to have this opportunity to present the findings of our studies on antibiotic prescribing for adult dengue patients in Taiwan. And this study is based on the collaborations between National Yangming Jiao Tong University and TAKEDA. I want to specially acknowledge the significant contributions from our first presenter today, Dr. Tai, and also Dr. Alan Lian, a graduate student from the Harvard University. And then, as you know, next slide, please. Next. As you know very well, that antibiotic resistance is a major global health threat. Potentially inappropriate antibiotic prescribing in healthcare is a major contributing source. The non-specific clinical manifestations of dengue and overlap with signs and symptoms of other febrile illnesses are common to tropical and subtropical zones, which make differential diagnosis between dengue and other bacterial infections really difficult, particularly in primary care settings where a lab test is a luxury. So therefore, it's likely to lead to inappropriate antibiotic prescribing among dengue patients. But how prevalent such antibiotic prescribing practice remains unclear. Our understandings of factors associating with antibiotic prescribing for dengue remains limited. So as you can see, next slide, please. As you can see in Asia, in Africa, and next slide, in Latin America, dengue has constituted a sizable proportions of acute undifferentiated febrile illnesses. And although dengue is non-epidemic to Taiwan, just like Ted has mentioned in his presentation, occasionally we have dengue outbreaks. Please, next slide. Next one. So we have dengue outbreaks occasionally, such as the major outbreak in 2014 and 2015. Next slide. Just provide you with a brief epidemiological information about dengue infections in Taiwan. Just like you see that Aedes albopictus breeds in areas throughout the entire island, but the Aedes aegypti is presumed to be limited to the southern part of Taiwan. And so in the past, all our major outbreaks are limited to the southern Taiwan. Next slide, please. Therefore, in this study, we aim to explore further antibiotic prescribing pattern among patients with dengue infections. In addition to commonly studied patient characteristics, we would like to move beyond the existing literature to explore physicians and contextual factors associating with antibiotic prescribing in adult patients with dengue infections. The contextual factors that we included in our studies included various care settings, such as inpatients versus outpatients. We also try to study separately the antibiotic practices for the time for the outpatient and inpatients before the dengue was confirmed, and also medical encounters after the dengue was confirmed. In addition, taking the advantage of the periodicity of dengue outbreaks in Taiwan, so we were able to compare antibiotic prescribing practices during an interval of heavy epidemic transmissions to a quiescent pre-epidemic interval. Next slide, please. As you can see, Taiwan has a rich availability of nationwide health-related database, which allows us to carry out the study, this study and the one that had just presented in his presentation at the population-based level of many nationwide databases. One most important one is the National Health Insurance Research Database, which records enrollment and claims information of 99.9% of Taiwanese residents, which is approximately 23.7 million people. Next slide, please. In these studies, we mainly linked the National Health Insurance Research Database to the CDC database based on the Taiwan's official infectious disease reporting system. And also we linked it to the mortality data and registries of medical personnel and medical facilities, which provide us the information on provider characteristics. Next, please. This study design was a retrospective cohort study. We first identified the confirmed dengue cases during a study period between 2008 and 2015 from the CDC database. And we excluded those without any medical encounter during a 14-day assessment period, and also those patients without complete information on independent variables. The final sample was consisted of 57,301 dengue cases. Next slide, please. Each dengue cases was assessed for his and her utilizations of outpatient and inpatient services, and also identify any of the antibiotics prescribed during the assessment period. The assessment period was defined as a week before and a week after the confirmed date of dengue diagnosis. And to be more conservative of our estimates, any prescription accompanied with a bacterial infection in one medical encounter was considered as no antibiotic prescription for dengue in that specific medical encounter. In terms of statistical analysis, we adopted generalized estimating equations to identify factors associating with antibiotic prescribing in dengue patients and controlling for the clustering effect. Next slide, please. As you can see that of the 57,301 confirmed adult dengue cases during the study period, 21.5% of them aged 65 or above. And only 7% of our dengue patients had an underlying major conditions. And 89.4% of our dengue cases came from the two epidemic years, 2014 and 2015. The more interestingly, that you can see that because of our national health insurance provides easily access to care, 97.8% of our dengue confirmed adult dengue patients had used outpatient care. And 33.7% of our dengue patients had been hospitalized during the study period. And most importantly, 24.6% of our dengue patients had been prescribed with antibiotics. Next, please. In order to further understand the antibiotic prescribing patterns under different contexts, we try to analyze the prescribing practices in inpatient settings and outpatient settings separately. In terms of outpatient settings, you can clearly see that, and then antibiotics was prescribed more often in a week prior to the confirmed dengue confirmation, and then which was 9.3%, which is higher than the prevalence of antibiotic prescriptions after the dengue was confirmed, which was 40.1%. And in terms of factors associating with the antibiotic prescribing, and there are similar patterns between the practice pattern before and after the dengue was confirmed. In terms of patient characteristics, you can clearly see that middle-aged patient had the least likelihood to be prescribed with antibiotics. Female patients and patients with underlying major conditions were at a higher risk to be prescribed with antibiotics. And then the likelihood of antibiotic prescribing in outpatient was significantly lower during the epidemic years. Next. You can see that during the epidemic years that patients were less likely to be prescribed with antibiotics. And then also, I think people might find it interesting is that we observed significant physician variations in their antibiotic prescribing practices to dengue patients. Older physicians and then ENT and emergency specialists, and then physician practices in clinics were significantly more likely to prescribe antibiotics in outpatient visits to dengue patients. Next slide, please. Okay, next. In terms of in inpatient settings, the prevalence of antibiotics was significantly, substantially higher than the outpatient settings. And also you can see that similarly that prior to the dengue was confirmed, the prevalence of the prescribing of antibiotics was much more prevalent. And in terms of factors, we observed similar patient characteristics who might be at risk of antibiotic prescribing when they got dengue. And then older patients, and then female and patients with underlying conditions were at a higher risk of being prescribed with for antibiotics. However, in contrast to the patterns we observed in outpatient setting, that we did not observe substantial variations in terms of the practice patterns in across physician characteristics. Only two factors seems to be relevant or related to higher or to a different practice patterns in antibiotic prescribing to dengue patient, which is physician volume and the practice level. And next, please. Yes. And this slide shows the top 5 antibiotics prescribed to adult dengue patients in outpatient setting and inpatient settings for your references. Next slide, please. In summary, about 1/4 of the adult dengue patients receive at least one antibiotic prescription during the 14-day assessment period. And as you can see, based on the findings on the factors, context really matter. And then we can see that significantly lower antibiotic prescribing to dengue patients after the dengue infection was confirmed. Also significantly lower in outpatient setting. Most importantly, is significantly lower in epidemic years. Next slide, please. This population-based assessment identified potentially modifiable circumstances that could be targeted for improved antibiotic stewardship. The findings on physicians and the contextual factors, such as care setting and during epidemic years, significantly influence the prescriptions of the antibiotics among the dengue patients. These findings, we think that may suggest the following 3 things. The most important one is that it seems that diagnostic uncertainty seems to play a significant role and in physicians' decision-making process to influence their decisions to whether or not to prescribe antibiotics. Therefore, to facilitate more timely and sensitive development of more timely and sensitive dengue diagnostic tests might help to reduce the potentially inappropriate antibiotic prescriptions. Another things that we can somehow get from the finding is that the significant variations across care settings seems to suggest the need for the care setting specific antibiotic stewardship strategies. One size fits all strategy is not sufficient to combat or to promote the prudent use of antibiotics. Another major finding seems to reflect that particularly the significant variations across physician specialties and physician age, which may suggest that we need to strengthen on-job physician training and educations on dengue infections and also the prudent use of antibiotics. That's all for my presentation. Thank you very much for your attention.
Thank you very much, Professor Huang, for that very insightful perspective of antibiotic use in dengue and how it can be brought down after diagnosis. Okay, last but certainly not least, we have Dr. Alberta Di Pasquale. She's the Growth and Emerging Markets Medical Lead at Vaccines TAKEDA. She's also a visiting professor of vaccinology at the University of Antwerp, Belgium since 2019. She has over 20 years experience in vaccines and has contributed to awareness and action efforts on modern vaccines, technologies, vaccine confidence, and the live course immunization. She joined TAKEDA in June of 2021, so perhaps just about 6 months now, to support the introduction of the dengue candidate vaccine TAK-003. And so who better than Dr. Alberta de Pasquale to take us through this dengue vaccine's TAK-003's efficacy and safety data. All yours, Dr. Alberta.
Thank you very much, Dr. Kurup, and for the nice introduction, and good afternoon to all. It's my pleasure to be here today. So I want to start by saying we have heard from previous speakers how chronic condition might impact dengue disease severity and clinical outcomes. And we have also seen data on the use of antibiotics in dengue management that is an important consideration in helping addressing antimicrobial resistance. But in my presentation today, I'm going to provide an overview of the TAK-003 candidate vaccine clinical profile as a potential additional preventative tool for reducing dengue disease burden and hopefully indirectly helping with these issues. So that's really the idea. Let me go to the next slide. And the key element, apart the disclaimer that this vaccine is not yet licensed anywhere in the world, is really looking at the structure of the vaccine. The vaccine is based on a tetravalent live attenuated viruses. It's based on a dengue 2 backbone. And the other three strains are really made as a recombinant chimeric structure where the pre-membrane and the envelope protein gene coding are inserted in the dengue 2 backbone. You see here in the illustration with the different colors. The idea to have such a structure is really to induce a broader immune response against structural and non-structural protein. That's really the concept behind it. So going into what has been the clinical development story of this product is quite an extensive profile. If we look at the complete assessment of phase 1, phase 2, and phase 3, where the several trials are still ongoing. And you see here more than 18 clinical trials have been conducted in 13 countries, involve more than 28,000 seropositive and seronegative participants aged from 1 to 5 to 60 years from endemic and non-endemic region. And what was observed again in the preliminary immunogenicity assessment is that the vaccine is able to induce immune response broad against a different part of the immune system, innate, humoral, antibody response, and cell-mediated response. Those studies also helped in identifying the dose selection that is then used in the pivotal phase 3 trial. So 2 doses, 0 and 3 months apart. And this was where this selection was done based on the observation that the immune response was sustainable and sustained for the 4 serotypes up to 4 years of follow-up. And again, the overall assessment in terms of safety shows that this vaccine is well tolerated with no important safety risks identified to date. But let me go now in more details into the pivotal phase 3 efficacy trials, the TIDES trial that is still ongoing. And let me start by saying that this study has 26 sites across 8 countries that are participating in order to allocate for different endemic regions where different burden of dengue disease might happen, and try to also find out and accommodate for different circulating serotypes. So after that, obviously, the study design is quite comprehensive. So there is obviously more than 20,000 children aged 4 to 16 years that have been enrolled in the studies in a randomization with the vaccine or placebo in 2-to-1 ratio. And the long-term follow-up is divided in sections based on when the primary and secondary endpoints were assessed, and the long-term follow-up obviously is still ongoing and is there in order to assess additional information about efficacy and safety. We are to date in terms of data released at the 36th month, and that's what we will be covering overall. So let me show you in more details what were the endpoints and the objective, and I want you to focus on the pyramid that you see on the right-hand side, because the pyramid really shows the hierarchy of importance based on the statistical power of the study. And obviously the primary endpoint is the one that is statistically powered to to show an impact of the treatment versus the control group. And in this case, this was vaccine efficacy against virologically confirmed dengue fever, regardless of serotypes. Then we go to the secondary endpoints, where really depending on the cases accumulated, we can really look at the efficacy per severity, like looking at hospitalization, dengue hemorrhagic fever, per baseline serostatus, and per serotypes. And the exploratory endpoint, again, you can go, and we went in additional assessments, are exploratory in nature, so obviously no big concrete conclusion can be driven, but hypotheses for further assessment might be generated through this data. So having said that, we go now into the details of the efficacy data shown into the phase 3 trial, starting from the primary and secondary endpoint. So for the primary endpoint, I guess a reminder, was assessed by looking at cases accumulated from 30 days post-second dose up to 12 months. And here is the main result. So as you can see from the main result, it's really the TACO-03 demonstrated 80.2% efficacy against symptomatically virologically confirmed dengue up to 12 months. This was obviously meeting the study endpoint and in the protocol study set. All 4 serotypes reported were present, but obviously there were very little presence of dengue 4 cases. And this is very much in line with the epidemiology of dengue that we know. The data obviously shows already a possible reduction that such vaccine might induce in the number of outpatient people with dengue fever. And if we go further into the secondary endpoint up to 18 months of follow-up, we can look here first at hospitalization rates. And again, we saw that TACO-03 demonstrated 90.4% efficacy against hospitalization caused by virological confirmed dengue. And again, the secondary endpoint was met. The hospitalization parameter is, for in my mind, even of higher importance, because it measures indirectly the reduction, the possible reduction that this vaccine might induce in the number of inpatient dengue fever cases, potentially reducing the burden, the bed occupancy, the cost for the healthcare system, and even the manpower capacity in the hospitals. The second element that was looked as well as a secondary endpoint was efficacy against dengue hemorrhagic fever. And we see here the data, very few cases reported, but overall an efficacy of 85.9%. But then when we go into the severe number of cases, the low number of cases recruited and assigned to that severity subset by the dengue case adjudication committee, that was an independent committee looking at the characteristic of the cases and deciding on severity, are too low in order to have a significant statistical assessment. So the jury is still out there. If we continue in terms of other assessments that were done, we see here again the efficacy against symptomatic virologically confirmed dengue by serostatus at baseline. So in the seropositive, obviously what we see is that there are 76.1% of the subject protected and 62.1 in seronegative, with overlapping confidence interval. And if we look at the same figure into hospitalization, similar to what has been observed regardless of serostatus, we see a higher vaccine efficacy. We see there obviously that is a 94.1% efficacy into the seropositive group at baseline versus 88.1% efficacy in the seronegative at the baseline. Again, quite comparable because the confidence interval are overlapping. Continuing into what was the efficacy against the different types, here we see the outcome that was assessed at 18 months, and the higher efficacy was observed for dengue 2, followed by dengue 1, and there was efficacy for dengue 3. But for dengue 4, again, for what I mentioned earlier, due to the low number of cases reported overall, there was no possibility to do a statistical assessment. As you can see, the confidence interval really includes the null hypothesis. And the last observation, that is an exploratory endpoint, so again, the results must be looked at with caution. It's really what is the dengue efficacy by serotype and serostatus at baseline. And we can see that the efficacy is established for dengue 2 for both seropositive, seronegative, for dengue 1 the same, for dengue 3 only for seropositive, but not efficacy for seronegative with very large confidence interval. And once again, dengue 4, we cannot assess the statistical significance of the assessment. So let me jump now into the immunogenicity and then safety profile of this study up to 36 months of follow-up. The immunogenicity first one I'm showing you here is in the baseline seronegative, where you can really see that the graph represents the geometric mean titers reported in a logarithmic scales in individual receiving the vaccine in the thick line as compared to the placebo in the dotted line. As you can see, GMTs remained well above baseline titers, especially for dengue 2, and stabilized from 9 months onwards. And the good news is also that 80.5% of subjects remained positive against all 4 serotypes up to 36 months of follow-up. And looking now at the seropositive, obviously the difference between the two is smaller, but again, the same observation that after TACO3, the immune response remained higher than placebo with a similar pattern of stabilization from 9 months onwards. And let me jump now into the safety profile, starting first by the local site reactions and solicited systemic events that were assessed. As you can see here, the data are reported as frequency of cases in children below 6 years and above 6 years. So solicited local reactions were reported more frequently in the vaccine groups, whereas systemic symptoms were more similar between the two groups. For sure, pain at the injection site was the most frequently reported event, followed by headache, myalgia, malaise, but in general, quite acceptable. If we move now into the unsolicited adverse events, we go there again and we see that overall the rates of unsolicited adverse events were similar in the vaccine and placebo group, and the most frequent serious adverse event was infection and infestation, but this was uncommon in less than 4% in either group of the study. And by the way, these were mainly nasopharyngitis, viral infection, upper respiratory tract infection. Last but not least, the severe adverse events collection, especially looking here at the period 18 to 36 months post-dose 2, there were no clinically meaningful differences in the severe adverse events between the experimental and the placebo arm overall and by serostatus, and this is very reassuring. And no severe adverse events were judged to be vaccine-related, including the reported deaths. So overall, no important safety risks were identified up to 36 months of follow-up after the second dose, supporting the good tolerability and favorable safety profile of this candidate vaccine. Most importantly, no signs of possible enhancement of disease was reported. So this brings me to the conclusive slide that again gives the overview of the primary, secondary endpoint, and then the long-term follow-up at 36 months. What we can say is obviously that the TACO3 demonstrated overall efficacy against dengue symptomatic fever in both seronegative and seropositive children aged 4 to 16 years. At month 36 exploratory analysis, we observed a tendency to a decline in vaccine efficacy in outpatient subjects, but with still a robust efficacy of 83.6% against hospitalized virological confirmed dengue, regardless of serostatus at baseline. We have also seen a variable efficacy against serotypes, and for sure no efficacy against the seronegative dengue 3 that will require further assessment. Last but not least, the reassuring element of no important safety risks identified up to 36 months after the second dose. Now, these data are obtained in children, and the question that you might ask today is, are they generalizable to young adults and older adults? Because as I know very well, in countries like Singapore, they represent the population with the highest burden of disease. So to answer the question, in line with what has been done with other vaccines, we have performed immunobridging assessment. to link efficacy and immunogenicity of this pivotal trial and this population with other trials in adults by showing non-inferiority of the immune response between GMT levels among the two groups. These data will be published in the coming weeks, so we will be able to look at them in details, and they have been submitted to regulatory authorities, including HSA in Singapore, to support the indication from 4 to 60 years of age, because dengue is a disease that really impacts all age categories. So in conclusion, the TACO-3 clinical benefit risk profile is favorable and is encouraging to consider this candidate vaccine as a potential additional tool to help reduce the burden of dengue diseases at individual level and on the healthcare system. And with that, I thank you for your attention.
Thank you very much, Dr. Pasquale, and I am happy that we have some encouraging news on the horizon. But you know, in the interest of time, we have only a few minutes, and we have some questions. So I would like to request the speakers to try to be succinct. I think there is a question, if I may direct that to Dr. Sai, on whether there's any data on hereditary spherocytosis increasing the risk for worse outcomes with dengue.
Thanks for the question. I'm not aware of any. There are some reports of G6PD deficiency, however, associated with more complicated courses. But hereditary spherocytosis, I'm not aware of anything.
Okay.
I would say, you know, the reason sickle cell disease is problematic is because of its impact on the vasculature system. And you know, the plasma leakage is associated with changes, not only inflammation, but also vascular permeability. And so you have small vessel disease and sickle cell disease, which I think is important.
Okay. So there's a question for Dr. Alberta, and this is with regards to any long-term follow-up data beyond 18 months. And the question also asks whether there's if or when there is any kind of booster expected in the pediatric population.
Yeah, thank you for the question. Obviously, the follow-up, as I said, is continuing up to 36 months. It's the status where we are now, but the data in the study will continue until 54 months. So this is for 4.5 years of follow-up. And after that period, the subset of children enrolled in the study will undergo a booster, and the booster assessment will continue for another 2.5 years in terms of efficacy and safety. So more data will come.
While you are talking on that aspect, can I hold you there and ask you, why did we not see any kind of antibody-dependent enhancement that was not seen in the, you know, that was seen in the previous dengue vaccine or the current one that we have?
There are obviously different ideas why this might be happening, but it's also based into the way the vaccine has been built. For example, the vaccine has been built on a dengue backbone, and the previous vaccines was built in a dengue fever backbone, where obviously you lose the non-structural protein that are very important in terms of inducing severe cases or inducing leakage like the NS1. And this vaccine is able to induce a large and cross-reactive antibody response against NS1. So that's one reason. But obviously reason might be that you have very high immune response and not just the humoral immune response. We have observed in some data sets cell-mediated immunity, innate response, interferon gamma. So probably the type of immune response is very much complete and able to control much better the disease and the risk of enhancement of diseases. But again, there are many hypotheses why this might be the case.
Okay, and also the efficacy for the dengue serotype 4, you're saying that's because the numbers were small, not because there is a true problem with the efficacy against serotype 4, am I correct?
Yeah, because obviously when we looked at the data accumulating with time, there is a tendency towards, for example, a positive effect in seropositive, but the numbers are so small that they are completely not statistically significant. So today, and this is quite normal because dengue 4 is really the least present and circulating type. And in these 8 countries where the study was performed, there were not enough cases of dengue 4. So today we cannot say what is the real impact of this vaccine to dengue 4, but the data so far, they tend towards a positive effect. But I mean, again, not very much certain from a statistical perspective. That's why further assessment will be needed.
Okay. And Professor Huang, why is it that females were given more antibiotics? Why is that a trend? And do you think that more rapid diagnosis for dengue is going to help mitigate that trend?
I think that it's because we know that gender, we know that it has been a literature shown that gender has, there's a differences in gender in healthcare seeking behavior, and then female in the literature seems to have or seek healthcare visits more. So I guess that the way to probably the patient education or the understanding of the physicians about gender differences in care seeking may help, and the rapid development or the distributions of the diagnostic test might help everybody, not just the female part.
Right, certainly. And so maybe one last question for Dr. Pasquale, and this is with regards to what you asked, and you hit the nail really with regards to the comorbidities as alluded to our speakers with regards to risks and whether or not we can just extrapolate immunogenicity data in that group, or is there any specific study that's going to be done with TAK-003 in the elderly or people with multiple comorbidities as such?
So in the current program, not yet, because obviously the data are firstly studied in healthy subjects, but I guess considering the importance of the burden of disease, that such studies might be undertaken in the future.
Okay. Oh, I see one more question on whether there's a need for prior serology testing, just what we do right now. I guess, is that something that you would do or not do for your TAK-003?
Based on the data, we'll not do it. And the reason is because we see, for example, for the dengue 1 and dengue 2, that there is efficacy against seropositive and seronegative. So regardless of serostatus, so that's, and the reason why the testing is needed for the previous vaccine is because there was an increased risk that, as we said, we don't see with this vaccine. So and considering as well that the testing always reduces the compliance, the acceptance for people to receive the vaccines because they have to be tested first and then receive the vaccination. So these are all reasons why the sero testing before is not recommended when you don't have a safety signal, and we don't have such safety signal.
Okay, thank you very much. We have come to the end of our session. We have timed out a little bit more. I'm sorry about that. Well, I'd like to thank all our excellent speakers for this little journey together in an hour or so, where we hope to look forward to a better vaccine out there that can help decrease this menace of dengue, also bring down antibiotic use as well, and give our elderly, those with comorbidities, a better life ahead for all of us as well. Reduce the antibiotic collateral, bring down dengue altogether. So thank you very much, ladies and gentlemen, and please enjoy the rest of the session. Thank you. Thank you very much.